Pioneers and Heroes is a documentary on the lives of New Jersey physicians serving in both peacetime and wartime in America. In their battles with homeopathic and osteopathic physicians, the Medical Society of New Jersey's physicians set standards of excellence in medicine. From the inception of the Medical Society of New Jersey in 1766, just after the French and Indian War, physicians organized to protect their citizens. Dr. John Cochrane, who was given the nickname Bones by his friend George Washington, was one of the founding members and first president of the Medical Society. Physicians serving in the Revolutionary War helped to vaccinate soldiers against smallpox. After the Revolutionary War, the Medical Society changed its charter setup under King George to a charter under the new American government. 5 district counties of the Medical Society of New Jersey, including the district in Essex County, started their society after the War of 1812. Civil War journal entries from the notes of the Medical Society told stories of physician soldiers serving bravely at the battles of Gettysburg, Appomattox, Vicksburg, and the Potomac. Their stories include finding a cure for scurvy, battling cholera, and marching with the wounded through marshes and yellow fever-infected swamps. Dr. William A. Newell, who was in Congress with his friend Abraham Lincoln, served as Lincoln's family physician. Newell later would become both governor of New Jersey and president of the Medical Society. Industrialized medicine gave physicians new challenges after the war as they fought the effects of chemical poisoning such as mercury in hat makers. After World War I, physicians were faced with the horrors of the bird flu. Millions died in the pandemic. Physicians in New Jersey rallied to the response of FDR's New Deal programs during the Depression. This included helping to set up free clinics for the poor. Penicillin was America's secret weapon of World War II, saving thousands of lives from war wound infections and pneumonia.
Dr. Capel, Chris Gordo, 6319, Chris Gordo, 6319, Dr. Capel, call the operator.
We are closer than ever to bringing more security to the lives of so many Americans. The approach we've taken would protect every American from the worst practices of the insurance industry. It would give small businesses and uninsured Americans a chance to choose an affordable health care plan in a competitive market. It would require every insurance plan to cover preventive care. Our approach would preserve the right of Americans who have insurance to keep their doctor and their plan. It would reduce costs and premiums for millions of families and businesses.
The system of fees for services has not changed a great deal in American medicine. Obamacare represents a considerable change in how that's administered, how doctors are paid by their patients or by their insurance companies. And it's hard to predict what the result will be.
There have only been 2 New Jersey doctors who have been president of the AMA. One was 60 years ago, and I'm the second. And the best thing about being president of the AMA is the ability to travel all over the country and see the incredible, innovative things that doctors are doing to make health care better.
In 1954, the Seton Hall College of Medicine and Dentistry was established in Jersey City, New Jersey. In 1965, the state of New Jersey acquired the college and moved it to Newark, where it was renamed the New Jersey College of Medicine and Dentistry. 1970, Governor Cahill signed a law merging the Newark and RUTGERS campus of New Brunswick into the newly named College of Medicine and Dentistry of New Jersey. Stanley S. Bergen Jr., MD, was hired in 1971 to run the combined medical complex. That year, ground broke for construction of a $200 million campus in Newark. The South Jersey Medical Education Act, signed into law by Governor Byrne in 1975, established South Jersey's osteopathic medical school. In 1977, Rutgers Medical School, known as the Robert Wood Johnson Medical School, affiliated with Cooper University Medical Center of Camden. Kennedy Memorial Hospital became the core teaching hospital for the School of Osteopathic Medicine. Governor Byrne renamed the college as the University of Medicine and Dentistry of New Jersey in 1981. UMDNJ became the largest freestanding public university of the health sciences in the United States. In 2012, Governor Chris Christie signed the New Jersey Medical and Health Science Restructuring Act, which integrated the university under the guidance of Rutgers University.
The UMDNJ got started. Okay. Back when the plans were to build a medical school, it was decided either to build a school in Newark or to build a school up in Madison. And of course, there was a big fight going on. There was a tiff between the people up in Madison area and the people in Newark. Newark people wanted it here, they wanted it up there. Dr. Albano had the foresight and plans to have this hospital built here in Newark because he felt this was the place where we can do most good and have patients to care for. So what he did, smartly, he went down to the sort of Bowery. He got 2 or 3 trucks and picked up some poor derelicts that were down there, and he gave them signs to carry. Big signs stating, "We want the hospital in Madison." And he said to them, "I'll give you each $5. All I want you to do is walk up and down the center of Madison with these signs as you are dressed and see what happens." Well, when they saw the motley group walking around in Madison, they finally said, "No, we don't want the hospital. We'll take it in Newark." And that's how we got started in Newark.
In the 1960s, new opportunities for research and medical education would prepare doctors of the future for practicing with new medical technologies. However, doctors would also face new challenges with the advent of corporate medicine. Noted author Paul Starr, professor of sociology at Princeton University, said in his book, The Social Transformation of American Medicine, "By making healthcare lucrative for providers, public financing made it exceedingly attractive to investors and set in motion the formation of large-scale corporate enterprises." Medicare began with President Johnson's administration. The cost of medical services rose from 3.2% a year in the 7 years before Medicare to 7.9% annually during the 5 years afterward. It was under President Nixon's administration that government passed regulations and legislation to hold down the cost of health care. Some of these organizations are health maintenance organizations in 1971, agencies reviewing proposals for new hospital projects, professional standard review organizations reviewing Medicare payments to hospitals, and state agencies limiting duplication of hospital services. In the future, more doctors will be in group practice, more hospitals will be in multiple hospital systems, and more insurance companies will be directly involved in providing medical care through HMOs.
The HMOs were so-called health maintenance organizations and were meant to streamline the health care of patients and streamline the ability of patients to have access to health care and also put more control on the costs of providing health care.
In 1978 or thereabout, the federal government started an initiative to regionalize all emergency medical services, including poison control. With the support of the people at Newark Beth, the support of particularly the executive director at Beth Israel at the time, Lester Bornstein, we were able to get the State Hospital Association to champion the cause as well. And then with some contacts with my own assemblyman, I was living at South Orange at the time, and that was Harry McEnroe, we got a bill passed in the state legislature calling upon the State Department of Health to develop a drug and poison information program for the state.
Paul Starr discusses the relationship between healthcare and patients' rights. Medical care figured prominently in this generalization of rights, particularly as a concern of the women's movement and in the new movements specifically for patients' rights and for the rights of the handicapped, the mentally ill, the mentally challenged, and the subjects of medical research. The new health rights movements were also concerned with rights in healthcare such as the right to informed consent, the right to refuse treatment, the right to see one's own medical records, the right to participate in therapeutic decisions, and the right to due process in any proceeding for involuntary commitment to a medical institution. The Medical Society of New Jersey took on the fight to protect patients' rights to health care benefits. The Medical Society worked with government regulators and legislatures in creating a fair health care system that both protected patients' rights while keeping down the cost of medicine. The Medical Society worked with the State Department of Health to develop an HMO report card challenging the insurance companies to provide the care promised in their contracts. The Medical Society worked with the state government to bring family care and kids care, which are federal programs for the poor. The Medical Society also supported the Vaccine Injury Fund to pay for patients injured by vaccines.
I do not like the way things are going to the centralized government. There's a marvelous thing with doctors being free. They work for you, and they can't get that understood by the public. When they work for somebody else, they're not working for you. If they got 10 doctors employed by some HMO somewhere, and a cost containment meeting that morning says no more this expensive, no more this expensive thing, and we can only have 3 operations out of this whole bunch, so decide who they'll be. And you're not going to get, they won't tell you that. The doctor will come to you and he'll give you something less. And they're not working for you now. And I think you should realize that they are under different constraints when you put them under government, and I don't like it one bit.
We worked on many different issues. One of them was mental health parity. We really never had mental health parity before, where if people would go into the hospital for a mental illness, they had a very small amount of money that could be spent on their care. It might be less than $15,000, and that would cover a lifetime. I also worked on a bill on prosthetic parity, and that bill became one of the strongest bills in the nation. Originally, insurance companies were covering for an artificial limb, they would cover 1 limb in a lifetime. And we, obviously, if you become an amputee when you're 2 years old or 3 years old, 1 limb in a lifetime is not going to work for you. One of the gentlemen that was the patient advocate for this actually was a diabetic and a double amputee, and his body was ravaged by illness. Both he was blind, he was a double amputee, and he couldn't get a new prosthetic to fit right, but he was working full-time, taking the train to New York every day so that he could put his 4 kids through college. And he was saying, I don't want to be on a state subsidy, I just want to be able to work. And they would not approve a new prosthetic even though it didn't fit right and he wasn't able to walk. And we were able to get that bill passed.
I think what I'm most proud of about this organization is they're focused on the patient and on public health and increasing health status. And I think a great testament to that, at least in my tenure here, has been the tremendous investment the society made in trying to achieve smoke-free air legislation. Public health legislation like that doesn't directly benefit doctors in any way, but certainly increases the health status and certainly is a core piece of our mission in terms of protecting public health.
There was a big rouse, a big tiff with optometrists. Optometrists wanted to prescribe, besides lenses, wanted to prescribe medication and so on. It was fought by the board, and they were not allowed to prescribe medication while I was on the board.
we instituted a program with the returning veterans, the military, to try to find the soldiers, the veterans that were coming back with traumatic experience to traumatic brain syndrome, depression, possible suicide, and we set up a program during my year to work with the military on that. And that was pretty exciting, and we thought that was a very good thing to do for the returning veterans.
In the early 90s, when Bruce Siegel was the Commissioner of Health, it was a time where many hospitals were in trouble. There had been changes in how hospitals were being reimbursed. The Commissioner had an idea that there ought to be many hospitals that ought to eliminate their pediatric services. There also was a new venture in that many hospitals were seeking to call themselves children's hospitals without any criteria being set to define what the status should be for children's hospitals. So the basic idea was for this clinical advisory committee to come up with criteria, basically to describe what ought to be at a children's hospital that would be regionalized throughout the state, and what ought to be hospitals that were less than children's hospitals, and what hospitals ought to have pediatric services, and to a certain extent, which hospitals ought not to have pediatric services.
There was always the attempt of the limited licensed practitioners, nurse practitioners, optometrists, chiropractors, always trying to increase their scope of practice, being able to do more things. There was a bill for chiropractors at the time where they wanted to try to do physicals on children in schools, and we negotiated a little better for that, negotiated out the physical for that. The nurse anesthetists wanted to practice independently without supervision by an anesthesiologist, and we were fighting that bill for patient safety.
Whether you like it or not, if you're in medicine, you're in politics. And those of us that have been there, and I was a lobbyist for 10 years in Trenton. When I used to come home from Trenton, I hope they get this on television, I used to take a shower, okay? Came home afterwards, at the end of the day, take a shower, clean myself off. I got out, I was still so grimy after leaving. I had to go back in and take a second shower to get rid of all of the corruption and the abuse and whatever.
In 1995, the country was introduced to drive-through deliveries in California. Now, the Medical Society of New Jersey, in particular, the Essex County Medical Society, took this goal on to try to pass a resolution. And our leader here was Dr. Anthony Caggiano. Dr. Caggiano was also working through the Obstetrics Society, and some of us were also related to other organizations. For example, I was with the New Jersey Pediatric Society. So Dr. Caggiano put together a bill, and we were either the first or second in the country. We're always close to Maryland and Massachusetts with these progressive bills. So I went to a good friend of mine, Senator Rice, from the State Senate Health Committee, who I had done a lot of work with in the past. What Senator Rice agreed to do was to present the bill in his Senate Health Care Committee as mother's choice and not doctor's choice. Well, we were able to get it to the floor and passed, and I think we were still the only one in the country able to do this. What happened after that is that Senator Bradley's team came to me and asked me to help them take this to Washington to make it a national bill. Now, this was already 1996. And if you remember, these were after the midterm elections in which the Republicans took over the House with Speaker Gendrich, and President Clinton was in office. This, as you remember, as I said, was during election time. We ended up having to embarrass some very powerful senators who were in charge of the committees that were not letting Senator Bradley's bill out. At that time, Trent Lott was Senate President and Newt Gingrich was Speaker of the House. Trent Lott would not put it on the floor unless he knew that Speaker Gingrich was willing to put it on the floor. And we were running out of time. Fortunately, we knew somebody in that small, powerful circle of Newt Gingrich, and he was willing to put it on the floor. And so it passed, and President Clinton eventually signed it, and it became the law where it is today.
The major discovery in our field is in reproductive medicine, is the acceptance of the in vitro fertilization. It took us 30 years to accept this, and we got a Nobel Prize in October 3 years ago. And this was given to Dr. Edwards, who is the physiologist behind the technique. And Dr. Steptoe is the gynecologist.
I have grown with the profession. When I first started, they used to say, can we save this patient? And now they're saying, should we?
We began to save children, which increased the cost because they were in an intensive care unit a longer time, kids that wouldn't have made it. And we got pediatric cardiac surgery to a point where we save lives and do surgery actually on babies under a month of age who would have died otherwise. Likewise, just babies who are not cardiac, who are in neonatal intensive cares today, that maybe a pound at weight and they're kept alive, and some left with abnormalities and neurological problems and others not. And it's awful hard ethically to know what to do at the time because you're never sure how they're going to turn out later on. You want to be sure, you want to, you know, nobody's God. You don't know what's going to happen, so you do the best you can.
Well, very important in the development of a healthcare system in New Jersey is that we have a sufficient supply of healthcare professionals to do all the things that need to be done. You know, so we've said that people need to take care of their own responsibilities for their own health. We also then need those healthcare professionals. And the University of Medicine and Dentistry of New Jersey has been involved in training healthcare professionals for our state for over 50 years. At both the New Jersey Medical School, the Dental School, the School of Health-Related Professions, now the School of Nursing and the School of Public Health.
There were no pediatric cardiologists in New Jersey. I was the first pediatric cardiologist in the state of New Jersey. The new medical school started at Seton Hall Medical School in Jersey City, and that's where I was asked to start a Department of Pediatric Cardiology. We had very few professors to begin with, but that grew and it trained a lot of doctors there in New Jersey, and eventually the Archdiocese sold it to the state. So then it moved to Newark, University of Medicine, Dentistry, New Jersey, there on Bergen Avenue.
Rose Prystowsky founded the Department of Child Psychiatry at the New Jersey Medical School. She was a past president of the New Jersey State Psychiatric Association. Dr. Prystowsky received the American Academy of Psychiatry Meritorious Achievement Award and was named to the list of the top 100 psychiatrists in the 20th century in America.
She was one of the few child psychiatrists, and but she's very humble. And you know, it's funny, if somebody couldn't pay her, she never sent them a bill. She just did it because they wanted to see her.
I opened up the first laboratory in infectious diseases in virology in New Jersey. I also developed one of the first fellowships in infectious diseases in New Jersey. And I've trained more people in infectious diseases than anyone in the country. Not only we were the first to describe HIV disease and set up the largest clinic in New Jersey, my son has found a new HIV virus, which he calls as HIV Newark, out of his special retrovirus laboratory.
The first cases of HIV infection in IV drug abusing population males and gay men, as was being reflected in New York City, was occurring in Newark. Unfortunately, that disease didn't limit itself to any population, and although in the beginning we didn't suspect that women were infected, and unfortunately transmitted the AIDS virus from themselves to their babies. And so the very first cases of what we call perinatal HIV infection was recognized by our group in Newark, New Jersey. But when we said that children got HIV infection, infants could be born with it, transmitted from the mother to the baby, it was a very, very unpopular idea. I think that threatened people that, well, if babies could get it, anybody could get it, and that's the truth of it. The most important thing we did in that era was realize that we had the option maybe of preventing children from getting infected. Infants got infected because their mothers were infected, and during pregnancy or at the time of delivery would transfer the virus from themselves to the baby. Myself and my OB colleagues, Dr. Arlene Bartigas, and others, had the abilities to write a grant called 076 that gave the first pregnant women who were HIV infected a drug called AZT, which was the first drug to treat AIDS. And there was a lot of controversy with that. People felt it was too dangerous to give mothers who were pregnant with a baby an anti-cancer drug, AZT, that was considered very toxic. But we prevailed, and miraculously, it worked. We were able to drop the transmission from 40% from babies to mothers, from mothers to babies, down to now where we have maybe 1 or 2 cases every couple of years.
I spent most of my time here as a trauma surgeon. Started the trauma service. We're the biggest level 1 trauma center. There's 3 in the state of New Jersey, and we're the largest. And we have a heliport on the roof of University Hospital. So not only trauma patients, but also non-trauma patients with cardiovascular disease are helicoptered to University Hospital for care. And because they get here much more rapidly, the salvage rate is much better. Dr. Benjamin F. Rush Jr. was the first chairman of the Department of Surgery, and it became a formalized surgical residency training program under his direction. Dr. Francis Chenard was chairman of the Department of Medicine, and he was a renowned internist. Dr. Carol Levy was his replacement. Dr. Levy is a specialist in diseases of the liver.
Well, this year, Blue Cross came out with a new product called the Omnia Plan, and the Omnia Plan is a tiered plan. So what it does is it puts certain hospitals and certain providers in tiers. So there's, in New Jersey, we have Tier 1 and Tier 2. The co-pays are very significant. So if you go to a Tier 2 hospital, all of a sudden now you have a huge copay. And there was no transparency with how a hospital or a physician gets in Tier 1 or Tier 2. The legislature has been engaged in asking why the Department of Banking and Insurance rolled it out when it wasn't quite ready. They have to approve all premiums, and it wasn't really finalized yet. And the public have many concerns about the hospitals that are in Tier 1 versus Tier 2. And you might have been going to a hospital your whole life for care, and all of a sudden now you find out that that copay is so insurmountable, it's forcing you to a Tier 1 hospital. But that Tier 2 hospital, no one said that their care wasn't cost effective and it wasn't a quality measure. We've asked Blue Cross to provide that information on a transparent basis so a healthcare doctor or a hospital can say, what can I do to meet that criteria? Many of them felt they were already working with Blue Cross on other programs to provide costs provide care at a low cost, high quality measure, but yet they never knew what the parameters were to get in Tier 1.
Physicians and patients need to understand why physicians are in what tier they're in, understand what clinical criteria or quality criteria was applied to them. And right now, none of the payers are telling us very much about what criteria were used. As a matter of fact, they're not telling patients that either. So we've called on Horizon and every other group that's putting in a tiered or narrow network plan to be honest about what the metrics are, to make them transparent to physicians, and to allow physicians to scale their practices how they wish, whether they want to be in a tier or they don't want to be in a tier, but let them know what the criteria are. Yeah, on the Affordable Care Act, it was clear that the nation needed to do something in terms of reining in healthcare spending, as it was just accelerating too much to be sustainable. So while we didn't love everything about the Affordable Care Act, there were aspects of it that did make sense. Covering children to age 26, eliminating pre-existing condition exclusions. Some of the insurance reforms were very much necessary. But I think as we go forward, we need to work on improving that act so that it works for both patients and physicians. Some of the patients have argued and complained, quite frankly, that the president said they wouldn't lose their existing health insurance if they liked their health insurance, or they would be able to continue to see their doctor if they liked their doctor. And both of those statements have borne out to be not true. And so we need to kind of make sure that the physician-patient relationship is protected as we move forward in healthcare reform and as we kind of improve on the ACA and make it better for both doctors and patients.
That was when I was president also. That was when the debate for Obamacare was actually starting. And what we liked, organized medicine really liked a few things. One was eliminating pre-existing conditions so that people could have insurance from day one and not have to wait a long period of time if they had diabetes or heart disease or any particular disease that the insurance companies wouldn't cover. We always liked having the children expanded so that they could be on the parents' health insurance, especially when they're just starting out in life and they don't have the money to buy their own insurance. They may not have a job that pays for their insurance. So it gave a few more years to allow the insurance to be paid for. And the third thing we liked was the no caps, no lifetime caps. Many of the insurance would say for if you had psychiatric illness, you would only be covered up to this many visits or this much dollars, and then your coverage stopped. How can you treat a disease when you have a limit? Cancer too, they would have a limit on the amount of money that they would spend on the treatment for your cancer. We always felt that that was poor.
People that I studied were mostly lead workers. And lead workers hadn't been studied much in the United States. I did all the work that I've described so far with Dr. John Maisaka, Dr. Vijay Badaman, Dr. Greg Lepat, and Dr. Barry Weiner at Jersey City and in East Orange. And we studied the people with renal disease, renal failure, modest renal failure. And it's become perfectly clear that not only does lead contribute to renal disease and hypertension in patients with renal failure, but it also contributes to lead poisoning, hypertension, and renal dysfunction in the general population.
STDs is a problem, and I know that Dr. Barry Prystowsky, being a pediatrician, believes that we should start sex education in the schools as early as possible, and as such teach our young the reproductive medicine and how pregnancy occurs, and thus influence the young to learn more about the sexually transmitted diseases, and then hopefully diminish that.
In a highly industrialized environment such as New Jersey, is chronic exposures, for example, to solvents in our oil industry or to other unspecified chemicals in our pharmaceutical industry. In particular, in the 70s and 80s, our emphasis changed from the just simply response to incidents in the workplace to a more preventive practice, and that we call occupational health. Occupational medicine is part of the Board of Preventive Medicine. The point of occupational medicine is to make and keep the worker well, to keep the workplace safe, and to keep the company productive.
Following World War II, African American physicians were being accepted onto hospital staffs. One of New Jersey's pioneering physicians in public health and surgery was Dr. William Verner. His daughter, Dr. Edwina Verner, also a New Jersey physician, talks about her father's legacy.
He was the chief of surgery at United Hospitals, also a hospital that's now closed, in the Central Ward in Newark. He was the chief of staff, both in the 80s. He was chief of staff and chief of the surgical department in the 80s at United Hospitals. He would accompany his father when he would make house calls, so had an exposure early on in his life to medicine. My grandfather actually was involved in founding a hospital in Mount Bayou, Mississippi, a very historically prominent hospital at the time because it was founded by African Americans to serve African Americans in a part and a time in the South when there was tremendous segregation and many African American citizens could not go to other hospitals to get care. He very early on was interested in preventive health care and early detection of disease. So he became a big proponent of teaching women early breast self-examination, getting mammograms early. He was also interested in things like smoking cessation very early in his life. He never stopped thinking of new ways to provide services. He never stopped coming up with what he felt were innovative ideas. Very late in his life, he developed something called interfaith health services, where he would go out and provide screening services free of charge. He got grants to do this so that he could then detect early illnesses such as hypertension and then get patients who might otherwise have remained undiagnosed into preventive services.
In the State Public Health Council, that was very important for me because I saw a different way of helping the people in my practice and people in general in New Jersey. It covered populations. When I chaired the Public Health Council, I chaired it for a couple of years. We had two interesting things happen. One was a bunch of families with children who were autistic come and meet before us, and I chaired it and listened to them. We had someone from Merck come for the vaccine people, and I listened to them and I felt for them. You always feel, you feel sorry and for the child who's ill and who causes problems, and but you can't plan the vaccines. They were never proven to be the cause of autism, and still to this day, up to date, it's not the cause of autism. Nothing proven with it. I've seen measles cause deafness. I've seen it cause encephalopathy retardation. I've seen whooping cough cause chronic lung disease. I've seen diphtheria cause heart block. I've seen polio cause paralysis. When I was at Hopkins, we had a whole unit just on polio. We got people from all around. I can tell you so many stories of what the diseases did. We're concerned also about vaccines for all of the state of New Jersey. And by the way, the vaccine issue, that has changed tremendously since I started. When I started, there was vaccination for diphtheria, whooping cough, and lockjaw in one injection, and smallpox. That's it. Now we don't give smallpox. That's wiped out around the world by the World Health Organization. But all these other vaccines came in later. But when I first came into New Jersey, into Nutley, in the Belleville area, I was seeing a lot of measles, mumps, German measles, chickenpox, you name it, everything, influenza. But now with all the vaccines, we see much less of that. It's much more on the prevention angle.
Claremont, I remember when it was built on Nanagoat Hill, and here in Belleville, as it was called, and there were 2 or 3 men that were very instrumental. It was Dr. Albano, Dr. Kreka, and Dr. Remondelli. These doctors had foresight to get the hospital land at a very relatively low price and build what is now the Claremont Hospital, and which has now become one of the leading hospitals in New Jersey.
New Jersey's hospitals traditionally, in their early years in the late 19th century, were founded by religious groups and ethnic groups to serve their own populations. Catholic sisterhoods, for instance, in Newark. There were also almshouses and poorhouses that were transformed over the years into larger general hospitals.
Many hospitals were difficult to enter into. Example, Columbus Hospital became a hospital for Italians particularly, and it was started out as a one-room house, became an OB house, which then two houses joined together to make it a larger thing. It was called St. Gerard Hospital in those days. And then from St. Gerard Hospital, they ran out of money, and they enlarged the hospital a bit by adding another building. Couldn't pay for it, and there was a lien on the building. So Presbyterian Hospital of New Jersey took over the Columbus Hospital for 2 years. And in those 2 years, finally, a group of Italians, Federation of Italian Immigrants and Italian doctors, plus some money from the city of Newark, were able to buy back the lien that was on the hospital, and they then called it Columbus Hospital.
I think medical progress has been very much an interplay between the desire of physicians and medical researchers, biomedical researchers, to understand what happens in the human body and thereby save lives. This is the heart of the pharmaceutical industry, not just in America, but in the world.
When I went to medical school, which was in 1961, 62, we were doing things rather differently than we do today. For example, treatment of patients with congestive heart failure, we would use what we call rotating tourniquets to try to occlude the circulation and reduce the load on the heart. There were very few medications that would be effective. We used to use something called mercuhydrin, which was an old-fashioned remedy to try to improve urine output. That drug is no longer used today. Whereas today we have a whole pharmacologic approach, which is quite a bit more advanced than it used to be.
We are now engaged also in tropical disease, which is now because of global warming. We're now seeing dengue virus coming north. We're worried about malaria. And we've seen immigration problems with worms, Chagas disease, amoebic disease, malaria, leprosy, as I mentioned before, and a host of other diseases that are seen primarily in South America and also in Africa.
One of the main things, and actually it started as a seed in the State Public Health Council, where a lot of patients were just, we see it today, running out of money to pay their medical bills.
Major problem.
Major problem. And I had that with my congenital heart that had multiple surgery, and they run out of money, and they'd start mortgaging their home, it's borrowing on their home, and so on and so forth. So I thought it wouldn't be a bad idea to try and see if I can get a catastrophic health insurance relief fund for children for New Jersey. So it took about 5 years to put through, and some legislators that you and I both know helped put it through. What you need is a good legislator who's interested in child health. And I remember it was Governor Kane. Tom Kane was governor at the time. He didn't want the money taken out of the Treasury. He wanted it to be sustainable on its own. We tried to put it on top as a surcharge on top of insurance companies. They wanted nothing to do with it. Finally, we put it on the unemployment compensation insurance fund, and it didn't cost that much because it was spread out all over the state. We ended up with about $15 or $20 million, and we helped an awful lot of children in the state of New Jersey.
But Milton Prystowsky was interested in getting legislation which would have people report kids being beat up. Everybody was afraid to do that because they could be sued. And lawyers, if you reported them and they got in trouble through it, they'd have a lawyer after you. So he got on the law that it was a physician's duty to report them as suspected child abuse.
The government's got involved, and now you have to do so many things on the computer that it's almost like the patient sitting in the chair behind you and you're treating the computer. You're putting everything in the computer, you're typing, you're reading in the computer, and you're sort of talking to the patient. Whereas you used to spend all your time looking and with the patient, and then afterwards you'd write a short note. That's all changed.
I come from a medical background. My mother was a nurse. My father was a physician. I grew up with them discussing medicine at the dinner table all the time. I sit in an unusual position as the president-elect of the Medical Society of New Jersey because my father is a past president of the Medical Society of New Jersey. I'm a firm believer in organized medicine. Organized medicine speaks for everybody. We have a profession. We have a profession that is as honorable as any other profession, more so than most. And we need to take pride in our profession. For doctors, where it is a 9-to-5 job, you're in the wrong profession. This is a calling. People's lives and their well-beings depend upon what we do as physicians. I think one of the biggest problems with our healthcare insurance system is that it has gone to a for-profit system. I'm not in favor of a one-payer system because then it's dealer's choice. You get what is given to you. But when there are for-profit considerations, it's not the care of the patient that is important, it's what dividends the investors are going to get in the company. When you purchase healthcare insurance, you're buying insurance that when you get sick, you will be taken care of. Unfortunately, the situation is let the buyer beware. Now, part of that is on him for not knowing what he signed on for, and part of it is on the insurance company. They're saving money on the backs of their clients.
Over the course of the life of a young kid graduating with an MD today, over his lifetime, the population of the United States will grow by almost 60%. The numbers of doctors in the United States in that same period will grow less than 30%. So we can't teach medical students now to practice the way we do. It's too time-consuming, it's too inefficient. Doctors in the future are going to have to depend on other members of the team to do a lot of things that we do now. I think that one of the choices that's very easy to predict is whether or not the United States will go to a single-payer system the way many European countries have. And I think that that is unlikely to happen in the United States. We are too entrepreneurial, we're too private, investment-oriented. So I think we will continue to have a mixed system, part private, part governmental.